So a regular afternoon, my name is Jairus from the Singapore Actuarial Society, and I'll be the moderator for the next two sessions. So coming up next, we have a presentation by the Singapore Actuarial Society COVID-19 Working Group titled COVID-19 Insights, Learning from the Past, Gearing for the Future. For this presentation, the working group will examine the impact of COVID-19, the impact COVID-19 has on the Singapore insurance industry, and analyze the present situation of the vaccine development and the rising threat of the new variant. Right. So without further ado, let me do a brief introduction of the speakers. First up, we have Charlene Lee. Charlene has 15 years of experience in the life and health industry, taking on various roles across the areas of pricing, valuation, and data science. She has recently dived deeper into the healthcare field with her move to Tan Tock Seng Hospital. Charlene is also a fellow of the IFOA and a chartered enterprise risk analyst, and is currently pursuing a master's in public health at the Imperial College London. Next in line, we have Kok Leong Choi. Kok Leong is a qualified actuary with broad experience across the life, health, and non-life insurance sector. He has been an actuary since 2011 and has been a member of the Aon Risk software team since 2016. Formerly a biomedical engineer, he retains an interest in health issues and contributing to solutions and insights in the health domain. He holds a bachelor's and master's degree in biomedical engineering from Johns Hopkins University and is a fellow of the IFOA. Last but not least, we have Jack Seah. Jack is the chief actuary of Igloo, a Singapore-based insurtech company. Jack's experience includes developing cloud-based systems in actuarial and data science domain, design and implementation of data and tech-driven insurance product. Jack is a fellow of the SOA, chartered enterprise risk analyst, and a professional cloud architect. Right. So do join me in welcoming Charlene, Kok Leong, and Jack. Right. Handing over the time now to you, Charlene.
Thanks, Jairus. Okay, just let me share my screen and let me know when you can see it. You able to see?
Yeah.
Yep. Okay. So good afternoon, everyone, and thank you for joining us today. So as some of you might know, this topic was supposed to be presented in person, but COVID got the better of us again, and here we are back on Zoom. So I must give credit to the organizers who very, very swiftly took a firm decision to convert this into a full virtual event, and all logistics, Zoom links, invites, and all that. These were set up within a day of notification. So this shows how, as a profession, we have adapted very well to toggling between virtual and in-person events. And this is a clear testament to how we have learned from the past and geared for the future, which is our topic for today. So before we dive in, just a quick background on who we are. The Singapore Actuarial Society, or SAS COVID-19 Work Group, was formed in July 2020, last year, and we had about 10 members. Jairus, whom you just heard, is actually one of the 10, as well as Kok Leong, Jack, and myself, along with another 6 others. So we came together with the common aim of supporting the actuarial profession, our employers, and our customers to transition into the new normal. We wanted to help build a better understanding of the impact of COVID-19 on the industry. And to this end, we have worked with the Monetary Authority of Singapore, the Ministry of Health, and the Life and General Insurance Associations to conduct surveys with our insurers in Singapore to understand their concerns and where the industry stands in terms of risk coverage, product development, pricing, distribution, operations, and risk management. So this was released to industry members earlier this year, around May to June. Along with that, we also seek to provide insights to help us get a better grasp on the risks that we're dealing with, or at least attempt to do so, because we can see how quickly things are changing each day. And this presentation was prepared with this objective in mind. And with these, we hope to support the actuarial profession in providing advice to our employers, which then naturally flows into impact to our customers. Today, this is what we will be covering. I'll first take us through the first wave in Singapore, which spanned around Q1 to Q3 last year, and give a broad overview of the types of measures that were put in place in Singapore to address this pandemic, to get a bird's eye view on how effective it was to rein in the new cases. I will also share some characteristics of the cases observed in the first wave, thanks to MOH for agreeing to share some data with us. Kok Leong will then take us through with an insurance industry viewpoint to talk about how this first wave made its presence felt on the Singapore life insurance industry, and with some comparisons against what we've observed in the first half of this year. Then Jack will take the stage, fast forwarding to today, or rather to last month, because that's when these slides were prepared. And here we zoom out to take an international view, keeping to the theme of Think Global, Act Local. And we'll be looking at a few countries which had somewhat of a head start in the vaccination process and what their country data shows. And then finally, I will bring us back to Singapore again to see where we are today and wrap up with some takeaways. So at the start of each section, you will notice that we specify the data period, and it might get a little bit confusing because the periods, they don't all coincide nicely, but we tried to order it chronologically as much as we can. But really, this is also a sort of reflection of the situation we're in today, right? Information is generated at different places, at different times, by different parties. Depending on what we can get our hands on, we then use it to the best of our abilities. So going into the first wave in Singapore. So the first wave was really quite unique in Singapore. If you just went to Google and you took some data off the public COVID websites that were showing things like cases and infection rates by country, it really wouldn't be quite representative of what we were truly experiencing at the time. So you can see from the graphs, the blue are the community cases, the red ones are the imported cases, and all these gray lines here, they represent cases from the foreign worker dormitories. And you'll see that the vast majority of cases, over 90%, are from the dormitories. And the reality is, this is a community with unique high-density living conditions, and their social interactions with the rest of the population are quite limited and quite different. On the other hand, the imported cases are really a function of border restrictions, as well as the profile of Singapore residents who were overseas at the time and decided to return. And then we have the community cases, which are the regular cases that perhaps in other countries would represent the main bulk of infections. But here in Singapore, in the first wave at least, this was only 4% of our total cases. So of the almost 58,000 cases over this period up to September 2020, there were three very distinct groups of cases with very different factors underpinning the spread. And because of this, we needed then three distinct strategies or measures taken by the government to address each of these unique groups. I'll skim through the next few slides quickly, just to give you a broad context of the measures taken. So looking at the community cases first, Singapore first recognized the gravity of this pandemic in early February when the DORSCON level was changed to orange. DORSCON refers to the Disease Outbreak Response System Condition, which is the framework that Singapore uses to demonstrate how serious a pandemic situation is. And this was even before the WHO declared COVID as a pandemic, which occurred in early March. Then from April to early June, we went into circuit breaker mode, which is what we call our full lockdown. And you can see the immediate impact it had on the new cases. So it dropped quite rapidly here. We then went through 2 phases of gradual reopening. With each reopening, we see a spike, it comes down, we see a spike, it comes down. And then we went into a fairly stable state thereafter. For the imported cases, we can see how Singapore really tried to keep the measures as light-touched as possible, starting with hospital isolation only for those who are experiencing symptoms, and they have been to China in the past 14 days. So this is up here. Within a week, this escalated to quarantine for anyone who has traveled to Hubei in the last 14 days. And then only a few days later, this was expanded to all of China. And you can see the trend of escalating measures, right? More cities added to the list, more countries. And finally, somewhere in the end of March, entry was now prohibited to all visitors coming in from all countries. And there were dedicated stay-home notice facilities set up specifically to house those returning to Singapore. So this effectively brought our cases down to almost nothing, which persisted for quite some time. But Singapore is a small country, and so we're highly dependent on relations with other countries. And around August, we started opening up again to other countries. And we see cases coming in naturally, but we had things like post-arrival test requirements, we had stay-home notice requirements. So we managed to keep this to a manageable level. And with the dormitory cases, really large-scale operations were put in place to contain the outbreak. So over a very intense period of 4.5 months, we had 3,000 government and privately hired personnel activated, with 170 teams deployed, with 24/7 support for food, hygiene, medical care, remittance. This included things like on-site medical facilities, mobile medical teams, thermometers, masks, sanitizers were distributed. So it was really quite impressive if you look at the speed at which the dorms were being cleared. And by August, the cases had really stabilized at a very low level. And of course, there was ongoing testing still being carried out to monitor the situation. So that was some of the measures that we took in the first wave. And now when we go into the data, we look at MOH data on some of the characteristics or distributions of the first wave cases. So when we look at residents, you can see over here, this is the population age mix amongst the three groups, and these are the cases. So we can see quite clearly that there's a relatively higher proportion of cases in the 40 to 59 age group, and also a relatively higher proportion of cases being male, about 50 to 60%, when our population gender distribution is about 50-50. So I'm not really in a position to pinpoint what the definite causes are for such trends, but I would throw some guesses, if I may, and these observations could reflect a few things. So the contact patterns of different groups, how they socialize, the number of people they come into contact with, these are different. It's not shown here in the charts, but when we compare the pre-circuit breaker period to during circuit breaker period, so during circuit breaker, there was quite a big dip in the proportion of young cases, accompanied by an increase in the proportion of older cases. So this could be, and I'm again throwing a guess, because a lot of the children, the students, were essentially stuck at home all day because school was transitioned into home-based learning. And if anyone had to go out and buy food and buy groceries, it would be us parents, not the kids. And so the kids' exposure was really greatly reduced, while parents could still be out there, either getting food and groceries or working in essential services. As for the proportion of male cases being higher, there's been reports of biological differences. So specifically, the expression of the ACE2 receptor is higher in males, which is believed to make them more susceptible to infection. There are also reports around the extra X chromosome in women, which then helps to associate us with a stronger immune system. Risk behavior between genders are quite different. So at the risk of sounding sexist, there have been reports of male invulnerability, which makes males less likely to comply with protective measures or to take symptoms seriously. And women, we are plagued by the worrier syndrome, so we become a lot more cautious and a lot more concerned. But I have to put a disclaimer out there. I don't mean to generalize gender characteristics, but these are factors that have been highlighted by a number of articles. And of course, in the insurance industry, something we are all familiar with is the difference between the true incidence and the diagnosis rates. So the young may have been more likely to be asymptomatic and therefore not picked up by screening or diagnosis. And for males, similarly, perhaps the higher prevalence of chronic conditions such as cardiovascular diseases, or coming back to the higher ACE2 receptor expression, this could mean they have a higher probability of having severe symptoms, which then means they are more likely to have gotten picked up by the system. We now move to the foreigner cases. So foreigner cases, it's quite skewed towards the 0 to 39 age group, you can see here. And the actual foreigner age group mix is roughly 40-40-20, but you can see actually 70% or more of the cases are in the 30 to 39 age group. And the males, this is quite amazing. So yes, there are more male foreigners than female foreigners in Singapore, but the mix is about 60-40. having 90% of cases coming from males is really quite extreme. So why? Well, again, I don't have the answer, but this could be a reflection of differences in social behaviors, where this difference is much more pronounced in the foreigner population than in the resident population. And with the gender differentials that I mentioned earlier, this could be playing a part here. But the fact that there are over 500 cases of males and only 50 over cases of females, either those factors are playing out to a much greater scale amongst the foreigners, or there's something else going on here that we haven't quite identified. So we move on now to the imported cases. We see a large majority of cases in the 0 to 39 age group. So during this time, during the first wave, we did have a large number of students in overseas universities getting flown back because parents were getting worried about their children continuing to stay in places where the spread was starting to get quite serious. And indeed, within the 0 to 39 age group here, those aged 20 to 29 made up the majority. Again, we're seeing a skewness towards males here, but I have to put it out there that we are missing the base distribution of everyone entering Singapore during this period. So we can't really say for sure how different this male distribution is compared to the actual male-female gender ratio of those people who are flying back into Singapore. And finally, the dormitory cases. So no surprises here. Most are very young. This reflects the demographics of the migrant workers in Singapore, and all the records that we received that were not masked were males. Okay, we move on now to the length of stay. So we split the length of stay into 3 groups: public hospital, non-ICU wards, and community care facilities, or CCFs, which were set up to house those who test positive but were clinically well with mild or no symptoms. And here in these graphs, we have excluded the dormitory cases because the demographics and experience there is quite different, as you'll see in the next slide. So as we expect, a confirmation of what we believe, length of stay increases by age in the regular and ICU wards. And this is, quite intuitively, we would link it to the higher prevalence of comorbidities as age increases. Very young patients over here, 0 to 19, seem to also stay longer. This could be intentional because we might want to keep them under observation for longer periods because they are young and they are more vulnerable. In the CCFs, you can see there's not much of a pattern here. So length of stay is quite consistent across age groups because those who are in here, regardless of age, by definition are quite similar in terms of health status. They're all infected, they're all positive, but they're all clinically well. As for the dorm cases, really few cases, I think 14 cases, had severe enough symptoms to be warded in ICU. The majority of patients, if you look at the N numbers here in CCFs and here in public hospitals, you can see that actually the majority of them didn't even need admission into hospital. They just went straight into the CCFs. And for those who did get admitted, the length of stay was really short, with most cases below 5 days of stay. And I will now pass it on to Kok Leong to share with you the impact observed by the insurance industry.
Thank you, Charlene, for sharing the insights from the analysis of the NMOH data. So when the COVID-19 working group was first convened by the SAS, the first project that we actually worked on was the survey of the insurance industry in Singapore to assess what insurance companies had seen in their business as a result of COVID-19. We shared the results of that survey earlier this year in June, and today's presentation is also a data-driven presentation. So it is in that same vein that we now turn from the healthcare data to look at data from the industry to assess how COVID-19 impacted the industry in 2020 and going forward. Next slide, please. So for this part of the presentation, we focus primarily on the life insurance industry using data from the Life Insurance Association of Singapore. We do not cover general insurance data as we did not manage to get permission from the GIA to share the data. The data from the LIA covers sales, distribution, and lapse statistics related to life insurance business in the Singapore market and is split by the categories indicated in this slide. We cover only Singapore onshore data and only highlights from the LIA data. So we will not be covering all elements of the data in our analysis. In particular, we cover mostly annual premium business, as sales from single premium business tends to be lumpy and depend heavily on the timing of new product launches. So next slide, please. So we start with individual life business. So in this slide, we look at the new business from 2019 to 2020, comparing year on year. So in this slide, we see the new business written comparing 2019 to 20, split by linked, par, and non-par business. And what is immediately clear is that there was a sharp reduction in business in Q2 of 2020. Now, this was obviously due to the circuit breaker that had been implemented in Singapore last year. So par business, which is in orange, was the most heavily affected. Now, par business constituted a reduced percentage of new business written in 2020 Q2 as compared to 2019 Q2. But it was a larger percentage of new business in Q3 and Q4 in 2020 as compared to the prior year. So there was a bit of a rebound effect in 2020 in Q3 and Q4, but we'll talk a bit more about that later in a subsequent slide. Next slide, please. So this is a different view of the new business written, and it shows the percentage change year on year. So as can be seen, even though there's a sharp dip in Q2, we can see that there was a very sharp recovery in Q3 of 2020, which moderated somewhat in Q4. Next slide, please. So we focus most on par products because, as we know, par products were the most heavily affected, and these tend to be usually annual premium products, which is why we are focused our analysis on annual premium products. When we drill down into annual premium products, looking at new business by distribution channel, it's very clear from this chart that all distribution channels were affected, but most severely for the bank distribution channel, which we see in light orange. Next slide, please. This again is a different view of the same data from the previous slide. Here we look at the growth rates in new business by distribution channel for annual premium products. Again, it's very clear based on the orange line that new business written by the bank distribution channel was the most severely affected, followed by tied agents and then financial advisors. Now we ignore the others distribution channel since it contributes to only a tiny percentage of new business. So the proximate cause of these sharp reductions in new business can be attributed to the circuit breaker measure, but specifically also in that the circuit breaker resulted in reduced bank opening hours as well as social distancing measures. Now, these obviously led to limited contact between advisors and clients. So this we attribute as the proximate cause of the reduced sales, particularly to these two distribution channels. Now, based on this chart, we see that a positive growth rate was recorded for both financial advisors and tied agents in Q3. Q4 was actually close to flat. So there was a bit of a rebound effect, but this was insufficient to compensate for the sharp drop in Q2. Now, if you look at the bank distribution channel, you can see clearly that the line is below zero for the whole of the year. So bank distribution growth was essentially negative throughout the whole of 2020. Next slide. So this chart shows the total individual life business. So this includes single premium as well. On the left-hand side, total individual life business, positive growth was actually recorded for 2020 versus 2019. So there was a growth of about 3%. And this can be largely attributed to growth in single premium products. We know this because when we look at the annual premium products on the right-hand side, we see that there was a drop of about 15.3% in 2020 versus 2019. So even though we saw a rebound in annual premium new business in Q3 and Q4 of last year, this was insufficient to overcome the drag from Q2, particularly as we saw this bank distribution channel recorded negative growth throughout 2020. Now, this is pertinent information today because in 2021 today in Singapore, we've only just emerged from 1.5 months ago from phase 2 heightened alert, which was very similar to 2020 circuit breaker in terms of the stringency of social distancing measures. So what we can expect going forward based on what we have already seen in 2020 data is that annual premium new business is likely to rebound somewhat, but it's probably going to be unable to fully compensate for loss of sales during phase 2 heightened alert. So this could, similar to 2020, lead to diminished new business for the full year. The industry can still record growth in 2021 versus 2020 because 2020 was similarly affected, so we are coming off a low base. Now, also, single premium products could once again drive sales as they did in 2020. But the main point from this slide is that because of phase 2 heightened alert in 2021, 2021 new business projections will definitely need to be adjusted, and annual new premium new business in 2021 could still fall short relative to 2019. Next slide, please. Yeah. So this slide shows the latest data, first half individual new business volume across 2019 to 2021, based on the latest available LIA data. So we can see that significant outperformance in the first half of 2021 was due largely to single premium sales. Annual premium sales, on the other hand, are still lagging compared to 2019. In addition, the full effect of the 2021 restrictions that we have just come off have not yet been seen in the data. So as a reminder, phase 2 heightened alert started on the 16th of May 2021 and ended on the 13th of June of this year. But there was a return to phase 2 heightened alert from 22nd of July to 18th of August 2021. So the effect of those restrictions are not yet seen in the data. So finally, next slide, please. This slide shows the split of individual new business by distribution channel, first half on first half of from 2019 to 2021. So again, we see that the bank distribution channel in orange has never recovered to 2019 levels. But we also see significant growth in the online distribution channel, albeit coming off a very low base. So note that this is total weighted premium, so it includes single premium and annual premium business. So online distribution is relevant mostly for single premium business, but we can see that it's becoming more important as a distribution channel in this chart. Next slide, please. So we're going to make a note on lapse statistics. Unfortunately, in our analysis, we weren't able to carry out significant analysis on lapse data owing to several factors. So one of those factors was that lapse amounts are available, but exposure amounts are generally not available in the data. In addition, we had insufficient granularity in the data by both single and annual premium. So just about the only thing that we can say based on the data is that lapse for annual premium products seemed to decrease markedly in Q2 of 2020 during the circuit breaker period. Superficially, however, lapse does not appear to have increased significantly on a whole year basis due to the pandemic. But we have to caveat this because lapses due to economic hardship may increase over a time horizon longer than 1 year. So another reason why analysis of lapse statistics is difficult for us to reach conclusions is because it's difficult to disentangle second order effects of the pandemic. So for instance, for those of you who remember, there was significant stock market turmoil in 2020 Q2, and this may have led to fewer lapses of unit-linked policies to avoid the crystallization of losses. Next slide, please. Next slide. So for group business, based on the data, we don't have many conclusions to offer either. But what we can say is that group business is largely sold on a pre-agreed contractual basis and is usually far less affected by either the pandemic or the pandemic control measures. So we saw some small changes in mix between 2019 Q3 and 2020 Q3, but we don't think those differences are significant. Group business actually grew slightly in 2020 versus 2019. So in general, we think that group business is largely unaffected by the pandemic or pandemic control measures. So that concludes this part of the presentation. And now I'll turn over to my colleague, Jack.
Okay, thank you, Toliang. So thank you for the study for Singapore. Now we look into outside Singapore to look at the other countries. So again, we prepare this slides in August. So we only capture data from 1st January to 15th August. And so this is before the current wave in Singapore. So for next slide, basically we look at 3 charts for a few countries. So the first chart is really the full vaccine rate. That means after 2 doses. So you see Israel had a rapid increase in the vaccine doses from January to March. Once it hits 60, then it stays relatively stable above 60%. And the second chart is we show the new cases by population. So by this way, we have a relatively comparable numbers between the different countries. But note that usually the larger countries, there is a lower population density and there's less medical resource to track the cases at rural areas. So overall, larger countries, per population cases are slightly lower. And for the third chart below, we have a stringency index from Oxford. So, but just take note that this indicates the stringency of the policies from the government. But when we look at the implementation, the effectiveness may be different. Some governments have very strict policies, but the population may have some protests, or just simply ignore the policies. So we just have to take note of that. So if you look at the case for Israel, I would say the period from February to May is very impressive work. And this is showing that this vaccine is really working. So after the vaccine rate hits about 25 to 30%, you will see that the number of confirmed cases start to drop quite significantly. And also at the same time, the government also reduced the stringency index from the February to March period. So this is a really ideal case. But recently, I would say since July, you will see the number of cases starting to grow. So this is a result of multiple effects. I would say, first of all, of course, it's a Delta variant, but also it's because of the vaccine start to waning out, and Israel, they are putting the third shot. And also it's probably because of the reduced stringency index since June. And maybe people are just getting tired of lockdowns and trying to go out more often and don't really want to wear the mask. Okay, so next slide, please. So for the next slide, we just compare 4 countries. I'll say the first one is Israel. We choose it because it was with the fastest vaccine rate. And US, the second is US because of its large population. Then we have Singapore, us, and also our neighbor Malaysia with a relatively low vaccine rate. So we also have the same 3 charts. The first one is the full vaccine rate. The second one is the case per population. And the third one is the stringency index. So for Israel, you will see that there was an increase in cases recently due to the Delta variant and also the waning immunity cases and also other non-pharmaceutical measures. But for USA, you will see that the vaccine rate increases relatively slowly compared to Israel. I would say this is a fact of a larger population. And also in some states, people are just more reluctant to take vaccine, especially in the southern states. So for Singapore, at least during the whole period of time from January to August, the number of cases is very low. And also we know that the line of vaccination is not very smooth because Singapore took different strategies. So by mid-May, the government, the main target was really to get as many first dose as possible. So the first dose increased quite fast, but the full vaccine rate didn't increase as fast. But by mid-June and July, the supply we got more vaccine supplies. So the second rate, full vaccine rate comes up. But Malaysia, by August, the full vaccine rate was quite low. So the number of cases start to grow up. So if you look at the vertical and horizontal lines, we do observe a pattern here. So once a country hits 25% vaccine rate, we see that generally the number of cases start to decrease. And also the government's stringency index also start to decrease. So this is observed for Israel and US. And for Malaysia, it didn't hit the 25% rate by mid of August, so we didn't see that effect yet. So this is kind of indicating that for a vaccine to take effect, probably you will need a 25% vaccine rate. And next slide, please. And also the last slide, we want to study something about the hospital and ICU cases. Then that's also what the Singapore government is focusing right now. So the two countries we choose are also, first of all, we choose Israel because it's a small country with a high vaccine rates. And we chose Germany because when we prepared slides, the government was opening a vaccinated travel lane with Germany. So if we draw a line for Israel and Germany at the 25% case line. So Israel hit that very early. So Israel is a blue color. So it hit the 25% in January. And Germany did it quite late. So it hits about 25% in May. So you will see that we observe the same pattern, both in terms of number of weekly confirmed cases and in the number of hospitalized cases, and also in the number of ICU cases. So if you look at the chart on the right corner, we also plotted a line of ICU cases versus normal patients. So this is the ICU rate per patient. So we see that the yellow line is actually lower when it's closer to the July to in the last 2 months. So we see that although we have a Delta variant hitting Israel, so the ICU rate is still lower. So this really shows the impact of the vaccines. So then I'll pass the floor to Charlene. Charlene will make a summary of our studies.
Thank you, Jack. Okay, so coming back to Singapore, and what can we take away? So still on the topic of vaccination, the chart you see on the screen is as at 23rd of August. So we can see that there is also a very clear difference in terms of the probability of having severe symptoms in the vaccinated versus unvaccinated. The proportion in ICU for those vaccinated was only at about 0.2% compared to 1.2% at the time amongst the unvaccinated. Nonetheless, I have to put it out there that when we compare this with the first wave, where over 2% of cases were warded in ICU, this 1.2 is still somewhat lower than before. And this could be a reflection of improvements in the care processes, in treatments, as we continue to learn from past experiences. It could be a result of active surveillance, where we pick up new cases more effectively and earlier and deal with them more effectively than we did last year. But as we saw from the experience in Israel, this really doesn't mean that we're out of the woods just because we now have a vaccination rate of over 80%. The Delta variant has quite clearly thrown us off track again, all over again. And at least in the area of transmissions, with Singapore just passing 1,000 cases a day again, we can see quite clearly the efficacy of the vaccines we have today is now quite limited. Immunity could be waning, as the first batch of the population who completed their vaccination here in Singapore did so more than 6 months ago. And just in the last 1 to 2 weeks, the ICU and severe illness cases have in fact shot up. And the government has stated that we're not ruling out another circuit breaker if this trend doesn't slow down. And vaccines aside, so coming back to the topic of public health measures, here we focus on the community cases this time, because during this period, over the last few months, the community cases really make up the majority of all new cases. So we can see from this graph, what I want to point out is how rapidly the measures are changing, where we enter into heightened alert, and then we go into phase 2 heightened alert, and then we reopen for a little bit, then we go reopen a little bit more in a controlled manner. Then we go back to heightened alert again, and then we reopen again. And it's not shown here on the graph, but we've just got our measures tightened again very recently. And all this was within a very short span of 4 months. So of course, these rapid changes are very disruptive, no doubt. But if we look at it more positively, one observation is that these measures are now much more targeted. So for example, it's not a blanket, everything shut down measure. They could say restaurants and gyms are closed because these are identified as hotspots for transmission because of the mask-off activities. while retail would be allowed to continue operating. So this demonstrates the insights that we have gained from studying transmission patterns in earlier waves, and it leads to decisions where we aim to maximize the impact of measures on new infections, but try to limit the economic impact on the community as much as we can. Another observation here is really the sheer agility at which the measures are being rolled out. You know, we've all learned to stay on our toes. We've learned not to take today's circumstances for granted. And we've learned to accept that tomorrow things may take a very drastic turn. And that's just the way life is nowadays. So when we look ahead, yes, the vaccination rate in Singapore is now over 80%. Yes, we are probably the country with the highest full vaccination rate. But with the threat of the new variant, the vaccination efficacy has been greatly reduced. You know, is herd immunity even possible today, given the R0 of the Delta and the new variants being much higher than the original Alpha strain? Singapore has started to roll out booster vaccines to some groups, and this is similar to what Israel has done to address the worry of this waning immunity. And so, with the pharmaceutical measures still continuing to play catch up to the virus mutations, the non-pharma measures like our masks, our safe distancing, our working from home, these will continue to play a very big role. We also see vaccine differentiated measures in Singapore already with dining out, whether you're allowed to dine out or not. And over in the US, well, some companies have actually implemented vaccine differentiated measures on their staff as well, where if you're not vaccinated, you're not allowed to go back into the office physically. Some even go as far as to impose this on all visitors and clients who step foot into their office premises. So over there, it's a little bit of a different situation because the US has now fully approved the Pfizer vaccine. Over here in Singapore, it's still on emergency use, and the process for full approval is still underway. So perhaps it's a little bit premature for most companies to start imposing strict vaccine differentiated measures. But when we look outside and we look back here, we have to admit that it's not something that we can rule out. So when we look at the insurance industry perspective, what should we do? We look at how the first wave affected our sales and operations. We look at how we rose above the challenges posed and continue to build capabilities like digital channels and providing supporting enablers for sales teams to operate under these prolonged challenging circumstances. Simpler products could do better under digital channels and virtual sales processes. And again, vaccine differentiated products or vaccine differentiated premiums is a very sensitive topic. But I think there have been some insurers elsewhere outside Singapore who have started to consider some of this. And COVID has shown us how one little virus has managed to turn all our worlds upside down across industries, across the globe. It has made the world band together in collaboration to face this one common enemy. It has highlighted the importance of timely data sharing so that we continuously learn from one another, almost on a real-time basis. And it has made all of us in every sector probably more agile than we've ever thought possible. So let's keep those lessons fresh in our minds, fresh in our hearts as we move forward. And if I had one last message to leave you with, it's this: there is no going back to pre-COVID. Our best bet is just to keep learning from the past and gear for the future. Thank you.
All right, thanks Charlene, Leong, and Jexia for the insightful sharing, especially relevant when we see like rising case count of COVID in Singapore. Right, so before moving on to the Q&A section, I would like to remind the audience that you can post your question in the Q&A using the Q&A function in Zoom. And also you can just upvote the questions that you would like to be answered, and we'll get to that in order of popularity. Right, so maybe I'll start off with a question from Mr. Chi. So this is regarding slide 14 of your presentation deck. So you showed, like he asked, you showed the length of stay, but were there any rates of admission by each group?
Yeah, Okay, I'll take this. Yes, I'm sure there is data of the rates of admission by age group. I remember seeing on the CNA article quite recently, I think yesterday or 2 days ago, on the age banded rates of ICU or death incidents by vaccinated, partially vaccinated, and fully vaccinated and unvaccinated. I believe there is such a table, and definitely MOH will have that data, although we don't have the full set of everything from MOH. A lot of the data that was shared was also masked to protect the identity of patients. And so the short answer is yes, there are rates of admission information out there, but no, unfortunately, I cannot give you the full information here.
Right. All right. Thanks, Charlene. So another question we have is on the statistics as well. So of the affected cases, do you have any statistic on the strain of the COVID virus that they have?
I feel like I'm being treated like COVID dictionary here. I don't have the strain statistics for the first wave because that was not part of the data that was shared. But I recall reading quite recently again in the news article that in the recent month, or actually in the recent few months, over 90%, the vast majority of cases are the Delta strain. So we are really getting hit today by the Delta strain much more than the original Alpha one.
Right, thanks, Charlene again. So I've seen a lot of questions regarding the statistics. I guess like Charlene mentioned that she doesn't really have the statistics. I think it's available on MOH website as well. So another question we have is regarding so do you think that actuaries can add value in managing this pandemic? Like example, engaging with policymakers in this pandemic situation?
Kok Leong, you want to take this?
Let me see.
So I guess I'll repeat the question again. So like, how do you think that actuaries can add value in managing the pandemic?
I think actuaries are data experts. So obviously our engagement with the policymakers will have to do with the application of both our expertise in data as well as our expertise in terms of the insurance domain. So we will definitely need to engage the policymakers in terms of how new products and practices will evolve over time in relation to how insurance is sold to the public at large, and also how claims are managed, because clearly there will be an impact of the pandemic on sales. For instance, as I've shown in my part of the presentation, clearly online distribution is going to be more important. And once something is more important, obviously the regulator might need to scrutinize it further. So we might need to take a lead in terms of understanding how customer behaviors change as a result of the pandemic. Are people buying more things online? And this applies to insurance as well. In addition to how we can engage policymakers in terms of the product sales, we can also engage policymakers in terms of what we are seeing in the claims domain. Because clearly, if there are claims from COVID, we will be probably among the first to see them. And it's still an open question as to how claims experience is going to play out, because over the past year, I would think that the government has underwritten many of the treatment costs associated with COVID. Part of the reason is because they don't want a situation to arise where people don't seek treatment because they're unable to afford it. But going forward, with the living with COVID as an endemic disease, that framework might need to change. So certainly the insurance industry, which is involved in claims, will need to engage with policymakers in that respect. Yeah.
Right. Thanks, Kok Leong. So I guess the next question is regarding the private insurers. So how do private insurers rework or review their integrated shield plan in light of the current hospital burden due to the high case count?
Sorry, let me just read this question again. Insurers.
Again, yeah, I can try taking a stab at this. So again, I would say that, like alluding to my earlier point about how the government has been paying for the medical care of COVID patients. But going forward, this may not be the case, especially since the government has clearly signaled that the majority of our cases, particularly those who are vaccinated, are mild or asymptomatic and so qualify for the recovery at home scheme, which has just been rolled out. So clearly that will impact on your coverage, right? Because if most patients are staying at home, what kind of claim can they actually file? What kind of claim are they eligible to file? So in terms of the changes to hospital coverage and your integrated shield plans, I think we'll need to, the people who are in charge of designing those products will need to be very watchful of what policies the government is rolling out, because that would definitely impact on design, pricing, and claims. So again, we will need to watch very closely what the government is intending to do. So far, it appears that they're signaling that because of our very high vaccination rate, we have the privileged position of being allowing people to recover at home because they're well enough such that, or rather they're not sick enough to warrant hospital care. But of course, there's that overriding motive of the government not to overwhelm the hospitalization system, in which case it could lead to extremely bad outcomes for the entire country as a whole. Yeah.
Right, thanks, Kok Leong. So I guess another question is regarding the private insurance as well. So have the work group actually considered impact on insurance claims from COVID? Now I know that the working group has actually did a survey on regarding like asking insurers on their claims impact. So maybe you can share a bit about that.
Yeah, just on the survey, this was done actually last year before we really would have seen the big major impact in terms of claims due to COVID. So what we surveyed the insurers on at the time were things like claims operations rather than claims rates. In order to get claims impact on claim rates due to COVID, this would entail data sharing by the individual insurers in terms of cost of claim in their proprietary data. And so the answer from the work group is we will not be able to unless our insurers are willing to share that data and come forward to share that with us.
Right. So I think in the interest of time, I think we'll just answer one last question. So, I guess the most popular one that is being asked is due to COVID, as people are going for GP, improving the loss ratio for shield plans and group health insurance, do you think this effect will last and make medical claims more sustainable? Or will we see a bounce back in the near future?
I'll try and take a stab at that. So, it could, like I said, because most of the costs for treatment of COVID so far has been carried by the government, but going forward, that may not be the case. So the improvements in loss ratio may not be sustainable as we open up, because part of the improvement in the loss ratio could also be due to the fact that more of us are staying at home, and as a result, there's less community interaction. And as an example of that, in last winter in the Northern Hemisphere, there was practically no flu season because essentially people were staying at home and it got crowded out by COVID. So as we open up, I'm not entirely confident that these improvements in loss ratio will be sustainable. And we also need to be mindful that of the impact of waning vaccines efficacy. Even with the impact of booster shots, we don't know how effective going forward, how protected people will be against COVID or the new variants that we have not even seen coming out. In addition, fortunately in Singapore, we don't have this situation, but in other countries where large proportions of the population have already contracted COVID as a result of the first waves last year, long COVID is certainly a concern on the horizon for a lot of people in a lot of countries, and we don't know what the long-term claim implications are for those patients. In Singapore, we're fortunate that we don't have that many cases from last year. So as a result, we don't really see the incidence of long COVID spiking up. But that's certainly a concern if we have decided to live with the illness. Thus far, articles have shown that vaccination does significantly cut the risk of long COVID. But again, there are no guarantees in this, so we don't know going forward. I would not bet on loss ratios improving for an optimistic period of time. I mean, things could easily turn south.
I just want to jump in on the medium term as well. So with COVID people are holding back on going to see the doctors for certain things that are quite important in terms of prevention. So screening has been cut down because people are scared to go to the hospital or go to the doctor, or they just prefer not to go out anyway. And that could then potentially come back and bite us again, because that means when it comes to diagnosis, people could be potentially at a more severe stage already because they missed the window of early detection. So I'm with Kok Leong. I would not bet on long-term continuous lower loss ratios in health plans.
Right, thanks Charlene and Kok Leong. So I guess in the interest of time, we'll stop here. I know I think like there's a lot of open questions right now, so maybe you guys can just stay by later to try to answer them in using the Q&A function in Zoom. With that, I guess we'll move on to the next presentations as well. Yeah.
Thank you.
Thank you.